Welcome to Grand Rounds for November 2009. Brought to you by A-OPTIC. Today's topic, Introduction to Myofascial Trigger Points, is presented by Dr. Laura Griffin, D.O. Dr. Griffin is Associate Professor and Chair of the Department of Osteopathic Principles and Practice for Pikeville College School of Osteopathic Medicine. Immediately following the lecture portion of our program, Dr. Griffin will take your questions. And now, Dr. Laura Griffin.
Hi, this is Laura Griffin, and I'm going to talk to you today about an introduction to myofascial trigger points. They are a very prevalent diagnosis that we see a lot in patients with chronic pain, which is going to be common in the family practice setting, in the internal medicine setting, in the OB gynecology setting, and certainly in the practice of people who do a lot of osteopathic manipulative medicine. And this is a tool that I have found very useful in augmenting what I do with manipulative medicine. So we'll talk very briefly about the history of myofascial trigger points. We'll look at some definitions so that we can all be speaking the same language about them. We'll talk a little bit about the pathophysiology, which is an evolving science that people are still learning a lot about. We'll talk about how we diagnose them with our patients, and we'll review some common trigger points and how we will treat them. Myofascial trigger points, although not under this name, were first identified in the mid-1800s, and over the years in the medical profession they've been lumped in with fibromyalgia, fibromyositis, fibrositis, and so on and so forth. And there certainly is some overlap, and some very recent studies have shown that there is some common features between fibromyalgia and where the points are that we test fibromyalgia for with common myofascial trigger points, and some common biochemistry that goes with them. However, they still remain two very distinct diagnoses because of the palpable findings that come with myofascial pain syndrome. We'll talk about that a little bit more. The person who really brought myofascial trigger points and myofascial pain syndrome to the forefront was Janet Travell, MD, and she became well known as the personal physician to President John Kennedy. She was one of the few physicians who could actually help him with his back pain, and got this appointment as his personal physician, and was able to start conducting quite a bit of research then. She then teamed up with another MD named David Simons, and they wrote a text which is just in its most recent, I believe, third edition, recently produced, called Myofascial Pain and Dysfunction, the Trigger Point Manual. I highly recommend that you have a copy of this available in your office. It's an excellent, excellent text, a great reference when you need it. So there is a very specific definition for a trigger point, so that helps you to not confuse it with tender points or Chapman's points or acupuncture points or any other kinds of points that you may hear about, or pressure points that your patients will talk to you a lot about. And the definition is a focus of hyperirritability, meaning low threshold for muscle contraction, that when compressed by manual touching is locally tender, and if sufficiently hypersensitive, gives rise to a referred pain pattern, and sometimes to referred autonomic phenomena and distortion of proprioception. And recent studies have actually shown that on both ultrasound and magnetic resonance elastography, which is a particular type of MRI looking at muscle tissue, that you can actually see distinct tissue changes and identify trigger points on imaging. So the science on how to look at these has really come a long way. Now, when we talk about the trigger points that give most of the problems to our patients, we're really referring to what we call active trigger points. They are symptomatic, and they have a referred pain pattern that is present regardless of whether you are actually palpating or not. So your patients may come in and describe a range of pain, an area of pain that fits a particular pattern for a particular trigger point, and those are called active trigger points. Latent trigger points are clinically quiet in that they really only hurt if you palpate them as part of your exam. When you palpate them, they may still reproduce the pain pattern, the referred pain pattern, but patients aren't experiencing that pain when it's not being palpated. The primary trigger point is that hyperirritable focus within a top band of muscle, and this muscle was activated acutely or chronically, chronic overload, to cause this problem. So it was either an acute stretch or an acute injury of some sort that caused this. This was the first injury that took place. A secondary trigger point is a focus that then becomes active because of its relationship to that primary muscle. And it's in a muscle that became active because of the muscle that was primary. It was either overloaded as a synergist to that muscle or as an antagonist to that muscle that has the primary trigger. So it's in a distinct anatomic relationship with the primary trigger point. Associated trigger points are going to develop in response to the compensation and or in the patterns of the referred pain. So you can get associated trigger points either in the pattern where the pain has referred to or in the muscles that are responding to the initial injury. And then satellite trigger points are in the reference zone of another trigger point. They're not related to the primary trigger point. So it usually works out that if you can figure out which is the primary trigger point, you're going to have your best treatment results by addressing that one first, and then not starting with the satellite or the secondary type trigger points. There's a lot of theory about the pathophysiology of what makes myofascial trigger points take place. There's been theories of neuromuscular injury and overload of the tissues, metabolic changes within the regions of the tissues, including circulatory problems, contracture of the muscles, again going to lead to circulatory issues if there is tightness and spasm in the region, and dystrophic changes in the muscles. Jay Shah is a prominent researcher in myofascial trigger points. He was a speaker at the American Academy of Osteopathy convocation last year in Little Rock, gave an excellent talk on this, and he has done probably the most meaningful recent research in myofascial trigger points. And he talks about a process called sensitization. It's a little different. It might make you think of facilitation in an osteopathic sense. Similar in concept, but in a different place. This is more locally at the tissue level. And what sensitization is that when these trigger points activate nociceptors within the muscles, and then if that noxious stimulus is sustained, if it continues, you get motor and sensory changes in the peripheral and central nervous system that create that referred pain pattern. And that is what he has found. He has found ways to actually sample the biochemical status of the areas of trigger points and found a lot of different information about that. Very good reading. There is other really interesting things about the central processing about the pain that takes place with myofascial trigger points. They found that it's processed in the same areas as other chronic type pain conditions. The hyperalgesia is processed in the same way. However, they've also found that there is abnormally low activity in the hippocampus at the same time that suggests that there is a dysfunctional stress response to this hyperalgesia that may then in turn maintain the hyperalgesia from my myofascial trigger points. So this is a very recent article, just about a month old, that is also got some really interesting points in it to read. So how do we diagnose this in our patients? The highest prevalence of myofascial trigger points and myofascial pain syndrome is going to be in females in their late teens to very early middle age. And those gender differences that we see decrease as they get older. As patients get into their later middle age, it seems to be fairly equal male-female. It's most common in postural muscles, so in the chronic overload sense, muscles that are constantly working to maintain upright posture or posture that we're having in our daily work activity. It's also very common in the muscles of mastication, and trigger points are actually becoming a well-known treatment for temporomandibular joint dysfunction, even in dentists and orthodontists who do not really use a manipulative approach to their treatment of TMJD. They are starting to really use trigger points and injections of trigger points as part of their treatment plan. The history that you get when you're interviewing a patient that you suspect has myofascial pain syndrome, the patients complain of a dull, aching pain, but it can be extremely intense at times. And they will often use the word a nagging pain that has been shown to show up very frequently in patient descriptions. The pain radiates, but does not follow a dermatomal distribution. And many physicians who are unaware of the existence of myofascial trigger points will think that the patient is fabricating or not being truthful about their symptoms when they describe a radiating pain pattern that doesn't follow a typical dermatomal distribution, but oftentimes it's related to something like a myofascial trigger point. And they may tell you that they've had some sort of a direct stimulus that started their pain, some kind of an injury, exposure to acute cold or an acute overload when they were handed something, say, that was much heavier than they anticipated, or a chronic overwork situation is really probably the most common that I have seen myself. Interestingly, though, you can also get indirect other causes such as visceral disease, arthritic change, emotional stress, which leads back to that issue with the hippocampus that we just talked about, or, of course, the activation by other triggers that we just discussed as well. When you're performing your physical exam on your patient that you suspect has myofascial pain syndrome, what you will find is a circumscribed, so very easily palpable spot of exquisite tenderness. It's that really quit it kind of pain. And if you press on it with your finger, the pain that your patient experiences is way out of proportion to what you would expect, and it reproduces that pain pattern that we discussed, that very predictable pain pattern for that given muscle. If things are sufficiently irritated, you may see a little twitch response. It's not the same as an actual muscle spasm. It's just a real short little local twitch within the muscle, and that is actually often diagnostic for myofascial pain. That muscle will usually have decreased range of motion, pain when you stretch it, and it may be weak or inhibited. When you're palpating myofascial trigger points, there are particular types of palpation that you use. Flat palpation is just a firm compression with a slight motion at right angle to the fibers. So if the muscle fibers are running this way, you'll put your finger on the trigger point and just palpate back and forth in that direction. Pincher palpation is using your forefinger and your thumb to use a pincher type grasp and roll the muscle between your fingertips. That's very commonly used in a muscle that you can actually get around that way, like the sternocleidomastoid. And then a snapping palpation is a very quick motion, like plucking a guitar string, and that's probably the one that best elicits that twitch response that we were just discussing. As far as treatment goes, there's many different types of treatment and a lot of different things being experimented with now. The most common treatment that you'll see people use is something called ischemic compression or pressure release. Essentially, you apply a gentle, steady, slow pressure to the trigger point until you feel the tissue start to soften and change, and the patient will say that the pain starts to recede. One of my favorite things to use is spray and stretch. It is using some sort of a topical vapocoolant that when you spray it on the skin, it evaporates so quickly that it chills the skin and essentially breaks that pain spasm cycle that is created by myofascial trigger points. And then you can get, once that is broken, you can get a really good stretch on the muscle once you have sprayed it, and really get some very visible changes in muscle length almost immediately. We'll demonstrate this at the end of the talk. One of the more common things that we use for that is ethyl chloride. They used to use something called fluoromethane that has, I believe, since been taken off the market for environmental pollution reasons. Injection is probably one of the other most common techniques that's used. A, because it's more billable, and B, because the really tough cases it works really well. The most commonly used anesthetic is Procaine. It has a little bit longer acting, will have a little bit more relief that will last longer with it. You can actually use saline. It still has the effect of disrupting the firing at the neuromuscular junction, so that works. Dry needling is a technique of taking a small needle into the trigger point and then just poking at it from several different directions. It sounds sort of cruel and unusual, but it's actually been studied relative to ischemic compression. They did a study to see which one had more lasting effects, and it actually had very good effects. You would think that it might create more fibrosis in the tissue, but it really doesn't seem to do that. Some physicians like to use steroids, Toradol, or some even a substance called Serapin. That's sort of a controversial topic. Initially, 10 years ago, when I first started even learning about this, there were studies that showed that there were no inflammatory products in a trigger point, so there was really no indication to use anything like a steroid. Jay Shah's work and some other recent work does show that there are some inflammatory markers that may be located, but there's still a lot of risk of using steroids in the tissue. As you know, you run the risk of muscle atrophy, skin depigmentation, or skin breakdown in the region. And I did have an African-American patient who had been treated by another physician multiple times with steroid trigger point injections, and she had little white divots and fibrotic areas in the muscle all over her upper back, which obviously is not going to get repaired. So I would really caution you in the use of steroid if you do decide to do trigger point injections. The most up-and-coming treatment is use of low-level lasers that has been shown to be relatively effective, and there's quite a couple of nice little studies out about that show that as a valuable use. I'm not clear on the billable nature of that, so I would do a little research before you made the investment in that equipment. We'll talk about some of the most commonly found triggers, and I'll show you how to use the diagrams that come in the Travell Trigger Point Manual. These are the muscles that we'll be looking at that I tend to treat on a fairly regular basis. There's plenty more out there. There's hundreds of these trigger points in the body because many muscles have multiple trigger points depending on the size of the muscle. So it really pays to become familiar with the ones that are most often seen. The sternocleidomastoid, as you know, has two heads, and the way that you read one of these diagrams will look first at the sternal head. You'll notice that at the bottom of the muscle there's a darker red area with little bits of stippling as it sort of fades out. You also see the darker red area at the back of the patient's head and over the patient's eye with the lighter areas of stippling. The darker areas are where you will almost always see the referred pain pattern. That is the most common, the most predictable. The stippled areas, the lighter concentration of the red, is where you may see the referred pain. And if you do the pincher palpation with the sternocleidomastoid muscle and roll that between your fingers, in the areas of those X's, that's where the most common trigger points are located, where those black X's are. You should, if your patient has trigger points, reproduce pain in the back of the head, over the eye, and possibly just down into the chest. Now, obviously, it's going to be harder to get to the clavicular head. Normally, you don't cut the muscle off to be able to palpate it like it looks like in that picture. But in certain patients, you can sort of roll the sternal head out of the way to get your fingers on the clavicular head. And oftentimes you'll get pain right in the ear, right behind the ear, over the eye, and that little red arrow shows you that sometimes it even refers to the opposite side, and that's not very common. Most of the time in myofascial trigger point referral patterns, they stay on the same side of the body. Quadratus lumborum is a hugely important postural muscle, as most of you probably already know. It's engaged, it fires every time you take a deep breath in because it has to anchor that 12th rib so that when the diaphragm contracts against it, the 12th rib doesn't get pulled superiorly. And it is also very important in our just regular standing posture. It has trigger points in two different areas. It has some that you palpate directly posteriorly, as the picture on the left shows. So if you come just directly into the muscle from the posterior aspect, you will get a pain pattern across the gluteus that almost looks in that picture like it represents pain from a piriformis. So if you see a patient with pain that resembles piriformis spasm, or pain in the gluteal region that does not respond, or you don't see hypertonicity in the piriformis, look for quadratus lumborum trigger points. The other ones in the picture on the right, you actually palpate more laterally. So you come in from the deep muscle mass on the side of the body. And the upper point refers around the top of the hip and a little bit even into the lower quadrant. And the lower point refers to the lateral hip in the area of the greater trochanter. Gluteus minimus, again, extremely important postural muscle. As you see, where it attaches on the iliac crest and to the top of the greater trochanter, it's very important in the gait cycle in maintaining a erect gait in the stance phase of gait. And so it is going to be aggravated on people on a very regular basis. And if you look, especially at the picture on the left with those two slightly more anterior points that you notice within the muscle, there is a very obvious looking pain pattern that almost looks like it might be an S1 dermatomal distribution. So if your patient comes in and they have pain referring down the lateral side of the leg, and they have a normal MRI or a normal neurologic examination, look for a trigger point in that region. It's a very common finding. You can also see it down the posterior aspect of the leg, about halfway down the calf, in the points that are actually more posterior within the muscle. So again, it looks maybe more like an L5 distribution of pain. Look for these in patients who you cannot explain why they have a radiating pain pattern with a normal neuro exam or normal imaging. Piriformis, again, we're all familiar that it's a common pain generator, and sometimes you can't get it to respond the way you need it to, even if you're doing what seems to be appropriate treatment. The trigger points that you see are really fairly local to the points themselves, and they tend to be one very close to the muscle's attachment at the sacrum, one further laterally out towards the trochanter. This is kind of nice to know because if you do come to the point where you feel like you need to do injections, the trigger point should be well away from the area of the sciatic nerve, and you should not be, they should be on either side of it. You should not be getting anywhere near the sciatic nerve if you do injections. Obviously, if you get your needle in there and the patient tells you they get a shooting pain down their leg, make sure that that's not just from the trigger point itself and that it's not their sciatic nerve. It's very common when you do an injection to reproduce the pain pattern, and a lot of times you know that you've gotten in the right spot because as you insert the needle, you will see the twitch response. You can actually palpate it right through the syringe because you tend to use a fairly fine gauge needle. Usually I'll use a 27 if I can get it. And you can feel the twitch response, you can see the twitch response, and you can often reproduce the patient's pain pattern. So it's really helpful to help you know you're in the right spot. Trapezius has several different points, and because it's such a huge postural muscle, and most Americans have terrible posture, these are really commonly seen. The upper trapezius point refers up to the suboccipital region and a little bit down sometimes into the shoulder. The lower one in the lower edge of the trap, the one labeled trigger point 3, actually refers up to the top of the lateral shoulder more frequently. The fourth trigger point is actually almost at the very edge of the spine of the scapula, the medial edge, and it refers medially into the border of the scapular region. The point that's actually at the medial border of the scapula then refers more centrally. That would be the trigger point 6. There's even more than these. Again, I would refer you to Dr. Travell's trigger point manual, but these are incredibly common. Here's another incredibly common one. So many of our patients who do manufacturing type work have their arms out in a position that they're kind of holding it away from their body, and levator scapulae is a major muscle that fires trying to keep that scapula stable up against the thoracic wall. And so you will find points in it in the lower cervical spine and just near where it attaches to the scapula, and it will be very burning and intense in that area and then radiate down the scapula and across the back of the shoulder sometimes. Here's another really interesting muscle, one of those muscles that you think, you learned about in med school and then don't really think about ever again because it's so seems small and inconsequential. Serratus posterior superior is a very common muscle that you see trigger points in, and the way you have to find it is to actually have the patient pull their arm out of the way to pull the scapula laterally so that you can get your finger on it, and then you will see pain that goes down the back of the arm and to the fourth and fifth digits, usually mostly just the pinky, and sometimes even chest wall pain that looks like that radiating down to the arm. So it's something to think about even in patients who you have decided have non-cardiac type chest pain. This is a really important place to look, because the pain pattern can be really obvious, or it can be really confusing, I guess I should say, compared to what your patient is describing that you may think might be cardiac in nature. The important concept in incorporating trigger point treatment into your average daily office visit is that you have to treat their somatic dysfunction first if you can, if you're comfortable doing OMT. The more you get the underlying dysfunctions out of the way, the more you will take the strain off the muscles, and you may not ever actually have to treat the trigger points. A patient can have a diagnosis of myofascial pain syndrome, and still you may not need to address the triggers themselves. You may need to address the underlying somatic dysfunction. It is also crucial to address posture. If you treat trigger points and you put your patient back in the same exact situation that they've been in that caused them, you're sort of a hamster running in a little wheel there. So getting patients to work with stretching of the tight muscles, retraining of the inhibited muscles, and really working on their posture is going to be very helpful, especially in the chronic cases and the people who you think are getting their situation from some sort of posture that they're in on a routine basis because of their jobs or whatever else they may be doing. Sometimes NSAIDs in the acute flares can be helpful. There's even studies out using topical diclofenac that have very satisfactory results. In very severe acute episodes, you may even want to use a muscle relaxer for just a day or two. Heat and ice, whichever one your patient responds better to at home, is fine. And then there's a structure called a Theracane that was developed really strictly for treatment of home treatment of trigger points. It's a very large cane with those two handles that you see off on the right-hand side of the picture that the patients can hold on to and then use the Theracane to reach the points around their back. It uses the same principle of ischemic compression, so instead of you mashing on their trigger point, they can do it themselves. You have to really instruct your patients carefully on how to use these, because sometimes it can cause a flare if they overdo it or they do it too hard or too fast. But for people with really chronic issues, these can be extremely useful. Of course, we all want to know how we get paid for using this in our treatment. The diagnosis that you need to use if you're going to do trigger point injections is myofascial pain syndrome, and the code for the ICD-9 for that is 729.1. The CPT codes are used there's one code for if you do one or two muscles and one code that's done for three or more. The payment difference isn't really that big according to Medicare, but it's just generally better to be more accurate for how you're going to do it. And most times if you're going to be injecting trigger points, you're not going to be doing just one. Usually you'll try to get as many in the area as you can to calm down to get the best result. So more often than not, you'll be using that 20553 code. You can use that injection code for doing dry needling. You don't actually have to inject a substance. If you do inject a substance, and especially if it's something that's a little more expensive, don't forget that you can also bill per cc of the substance that you inject as well. So the injectables are separately billable. I will just refer you back to this PowerPoint that you can look at later on some of the studies that I have found really interesting in terms of myofascial pain syndrome. There's been a recent one that shows very definable myofascial trigger points in men with chronic prostatitis and chronic pelvic pain. And there's one about the overlap of myofascial pain syndrome and fibromyalgia. So I think that that is a useful thing. This is the study I was referring to by Dr. Shah on the biochemical milieu of myofascial trigger points, and that is fascinating and actually relatively readable article, and he's an excellent speaker. If you ever get the chance to hear him, he's really entertaining and really wonderful. And that would be the end of our PowerPoint presentation. Now we will go to our demonstration. The first thing I'm going to do is demonstrate the location of the sternocleidomastoid trigger points, and then show you how to use the spray and stretch, how to use the ethyl chloride. If you recall, turn just that way a little bit, the sternocleidomastoid, we'll just look at the sternal head, runs from right here all the way back up to the mastoid process. And this is a place where using that pincher style palpation allows you to kind of roll the muscle between your fingers to see if they have the trigger point. She does not, which is good for her. If she did, she would be experiencing some pain in the back of her head, and usually over her eye are the most common spots. So when you want to do spray and stretch, what you do is put the muscle on stretch first. And so since sternocleidomastoid side bends towards and rotates away, we're going to do the exact opposite and side bend her away and rotate her towards us to get, and you can see the muscle come out on stretch. The way that you use ethyl chloride spray is you get about 12 inches from the muscle that you're going to spray. You go slowly. Some people feel very strongly about going in only one direction, others don't. Usually about 3 swipes, and then stretch the muscle again. What is important to know when you're using it is that you have to depress the plunger fully, because if you don't, it just drips. So you got to press it down all the way. You can't be tentative. So you put the muscle on stretch, get about 12 inches away, spray slowly down from the one end of the muscle to the next. And it's nice to warn your patients. I showed Susie this before we started, how cold this was. It's very cold. And so it's nice to warn your patients. You may see the hair frost up a little bit or on the clothing, and that's okay. It will go away. It does not stain clothing. And then put the muscle on stretch, and you can see I'm getting further stretch on that muscle by doing that. Okay. As we discussed, the trigger points for the quadratus lumborum muscle are usually right in the belly of the muscle. There's 2 that go straight in. To find where you are, you find the iliac crest and the 12th rib, and then the muscle is going to be right in between it. You're palpating through the erector spinae when you do this, and then you just get in and try to find them that way. And then Susie, if you could roll on your side to face me, please. And bend your knees up just a little bit. Good. And then the lateral points, you locate where the muscle is again using the same landmarks, but then come in a little bit from the side to find where those triggers are. And to stretch, this is usually a good place to stretch the muscle from too. You can have the patient hang their upper leg kind of off this way, and then take their arm and sort of stretch them this way, and then you can spray the muscle from here. I won't take Susie's lovely Pikeville shirt off to do that, and then stretch them from here like that, in that kind of a position. For the gluteus minimus muscle, if you recall, there are 2 trigger points that you locate for that. In the anterior part of it, so find the greater trochanter and kind of come directly superior, usually one about there and one about there for the anterior spots. Those are the ones that usually produce the sort of S1 style distribution down the side of the leg. And then the other ones, the more posterior points, there's usually one big one right near the posterior, the attachment kind of right in the middle of the fan shape of that muscle, and usually right about there, and that gives you the more L5-ish style distribution of pain for those kind of points. To stretch that particular muscle, you get your patient to come very close to you on the edge of the table, and then let the leg hang off again, and put the muscle on stretch this way from that direction. And that's how you get the gluteus medius. Go ahead and roll over on your stomach for me. The piriformis tender points, again, the attachments of the piriformis are at the edge of the sacrum on the anterior aspect out to the greater trochanter, so the muscle spans about this kind of a range, so about that kind of a range. And then the points are usually one very close to the proximal attachment, and then one not all the way out to the trochanter, but an inch or two in, and the usual points are in there. And then to stretch that muscle, there's a lot of different ways to stretch piriformis. I will usually tend to do it with them on their side and then letting the leg kind of internally rotate and hang forward. It's kind of an awkward one to demonstrate. Or you can, again, get their leg kind of hanging off the table and internally rotate. If you come all the way to the side here, it's hard to do, but you can get the leg coming down this way and then bring it in underneath the edge of the table to do that one. I usually find that I don't spray piriformis very often. I can usually get that one with muscle energy or counter strain if I need to. For some of the trapezius points, they are, as I mentioned before, scattered throughout, and you can refer back to the diagram in the PowerPoint. One of the ones that I find most often is out towards the acromion in sort of almost superficial to where the belly of the supraspinatus muscle would be, usually right about in there. And if the patients have that spot in there, it will refer up to the back of the head like that. To put that one on stretch, in order to spray it, again, you kind of come forward and adjust the chin in whichever way you need to get the best stretch on the muscle, and then spray that long fan shape of the muscle coming out this way. Usually I try to get kind of that part of it, all the superior fibers. Levator scapulae, as you know, runs from the lateral aspects of the mid-cervical vertebra down to the very little corner of that scapula right there, so right in this range. Its pain pattern is relatively local, comes down along the border of the scapula in this way and stays right in there. And again, I usually stretch that one. You can have the patient hang on to what they're seated on, so that that sort of anchors the scapula. You can have them lean their body away a little bit to anchor this end, so that when you put the muscle on stretch, you're really fixing one end of it, so that when the other end stretches, when you move the other end, it stretches better. And then I'm going to go ahead and spray on this one, Susie, just to refresh how that was done again. And straight right down this way. And you can see that when I just depress it a little bit, I get drips. Usually these come with a little cardboard sleeve on them. That's a drip catcher. I'd keep it on there. Most people throw it out not knowing what it is. And then just put that muscle on a little bit more stretch. Okay. The very last one is the serratus posterior superior. And as I said before, the best way to find that is to ask the patient to reach their arm across to their opposite shoulder. Pulls the scapula out of the way. The muscle fibers usually run right around in here, and they run at an angle, so you usually have to palpate them this way. And most times I find the point relatively around like the third rib, right about in there. That's a little sore on that one. And then would spray it going in this direction, coming like this. And then the stretch, I usually will get right in it and actually apply like a myofascial stretch with my thumb to kind of really pull that scapula out of the way. And that's that. All right. Well, we have got one question so far from Dr. Ripley, and the question was, with the sternocleidomastoid spray and stretch technique, he usually has the patient hold their hand up to shield their eyes. I actually think that's a very good idea. You want to be pretty careful about getting this anywhere near someone's eye. I think my aim is pretty good, so I don't usually have to do that, but you never know. You want to try to avoid that. The other muscle that I often see that I need to do that with is probably the scalene muscle. And I thought if we didn't have any other questions, I might actually go ahead and demonstrate how I do that one as well, because it's so useful. Susie, if you could just slide down to the edge of the table here again. Thank you. And scalene, again, has a pain pattern that reproduces very similar to, say, even possibly cardiac chest pain. You'll get pain right in through here, right around the edge of the scapula, posteriorly down the arm all the way to the finger, and then anteriorly down the arm as well. So this one, again, it's very important to have the patient hang on to the side of the table. You want to make sure they're sitting up nice and tall, lean their body away to lock out that scapula. And then I usually have a series of things I do for people with really tight necks. Sometimes this is a really good thing to do when someone comes in acute spasm and you can't actually do any OMT. You want to maybe just do something to settle it all down and bring them back in a few days to treat them. So a lot of times if I go through my whole kind of acute neck routine, I'll have the patient just lean straight over to the side to get the more posterior scalene and more lateral muscles, and then again do the spray. And keep your eyes closed, Susie. There we go. And like that. And then I will have them, you always have the patient change position from neutral. You don't have them drop their head forward or back when you already have the muscles on stretch. So then I have the patient drop their head forward and then lean off to the side. Now you can tell I'm getting the posterior muscles a whole lot better. And we'll do the same thing to get the traps and possibly even a little bit of splenius in the back here. And then for scalene, which is a really important one to do because of the anterior middle scalene sitting, the brachial plexus emerging right between them, what you do is have the patient go to the side but then look up to the same side that they're on and lean away. And you can actually tell if you're in the right spot because you should see the muscles actually kind of pop out towards you. And then, again, this is probably one that I might have the patient cover her eyes on. She's got hers closed, and I promise not to squirt her in the eye. So again, about 12 inches away, slow, and right down towards where it attaches on that first rib, like that. And then I usually just apply a little bit more manual stretch. And you can actually visibly see the change that it'll make. All right, come on back. And with the demonstration of pelvic muscle spray and stretch, I got the impression that you would spray and stretch over clothing. Do you use the spray and stretch over clothing? Occasionally, I actually have used spray and stretch over clothing when it's been really awkward. If it's a thin shirt, you actually can do it. I just, for the piriformis and gluteus and quadratus, I didn't want to unclothe Susie on camera to do it, so I was just trying to demonstrate where exactly I would do it. Usually you can just drape a patient with a sheet or a gown and get them in a situation. If you need to do piriformis, you can do it right over their underwear. It usually works just fine. You don't have to be on bare skin. Better if you can be on bare skin, but you don't necessarily have to. Any other questions? Or did I just explain it all that well? Oh, somebody's typing. Yay. Oh, thanks, Dr. Ripley, for keeping the questions going. Oh. What stretches would you recommend for a patient at home with serratus posterior superior? That's a really tough one. A lot of times, Susie, why don't you swing your legs around the other way? Well, actually, stay right there for a second. To get it, what you would have the patient do is take their arm, pull it across their body, use their other hand to grab onto as far up their arm as they can and pull straight across. And depending on, I always make patients do their stretches right in front of me and say, are you feeling that in the spot that I want you to feel it in? And so if they are not actually feeling it in the spot I want them to feel in, then we make adjustments. So I may have her pull the arm down lower and then pull across, and then to get those stretches down through there. So I don't need to have her turn around to show you, but it's pulling the scapula out of the way. And a lot of times, too, dropping the head forward may actually help. Because serratus attaches really to the ribs, it's really challenging. Leaning away is going to be the biggest thing to do and get those muscles back in there. But it's a good question because it is really challenging. So, all right. Any other questions? Do I have a reference for stretches and patient handouts? Yeah, I actually do have some stretches and handouts that I got from one of my residents when she took the Greenman exercise prescription course, and I have just copied those and used those. That's an excellent course. We talked a little bit in the lecture about using stretching for the tight muscles and then strengthening for the more inhibited muscles, the antagonist muscles that are going to be inhibited by the spasm that takes place in the tight muscles. And that is the whole key piece of what that course is about. It's a really, really good course, and it allows you to really address all the postural imbalances and chronic patterns that people have that make them keep coming back with the same somatic dysfunctions over and over. So you could go take the course to get the handouts. There's also some really good ones online that are free to take. So usually if you just do an online search, you can get some through some of the physical therapy sites as well. American Academy of Family Practice has some stretches and some exercise things that I'll use for certain things. I love their patellofemoral syndrome handout and exercises. So it just depends on what diagnosis I'm treating, for what source I use for patient information. But I do like to give handouts when I can. It gives the patients a visual reminder that you've given them some homework to do. And I like to do things like that because it keeps the patient invested in getting better as well. It's not going to work out that well if we're the only ones doing the work. So, any other questions? It does not look like it. If there are no other questions, I will probably wrap it up. You can certainly email any questions you have back to A-OPTIC, and they can forward them on to me if anything else comes up. And thank you very much.